Okay, welcome. It is October 31, 2023, Halloween evening, and we're here at the Deuk Spine Institute. Our patient is from Cleveland, Ohio, moving to Florida. He has horrible back pain. He's got several problems. You could see he has spondylolisthesis at L4-L5, grade 1 to 2. And he's here because he's having back pain and leg symptoms. He's got facet joint pain as well. We're going to treat that. But he definitely has this listhesis issue. How is he? Awake? Reliable? And we're going to try to fix it for him. He's got gigantic herniations. AP? Yeah, he's got a grade 1 to grade 2. He's right on the border of grade 2. That looks pretty damn good. We're right at the back of the disc.
Thank you.
Lay still, you're doing great. What? No. Not moving at all. I'm just encouraging him to be all that he can be. All right, so we saved the hardest surgery for the last. This is a patient with obviously a spondylolisthesis, and he does not want fusion. I don't blame him. So we're going to try to fix him without fusion. We're going to go transforaminal. Of course, most doctors would do fusion, but he doesn't want it shot. I don't blame him. AP, are you okay? It's very, very challenging to do this surgery. So take your time. I'm glad he's not completely awake yet. Shot? Because I may want to start a little higher on this side. And he's a real stretch to get down to L4-5. I feel the facet. Shot? Shot? All right, let's just see AP. He's got a giant herniation in the foramen. That's good, actually. Thanks. On both sides. Let me know when you think he's ready. Shot? Now he's got facets too, right? Do we want to treat his facets first? You think he's almost ready?
He's ready. Yeah, I think he's good.
All right, let me know when he's fully awake. And we're not doing the iodine because he has a history of hives with iodine. So, are you awake?
Can you open your eyes for me? Okay, can you open your eyes for me? Good. Okay.
You're doing great. Just lay still.
Lay still. Put your head down for me, okay? We're going to ask you some questions. He's waking up.
AP. Yeah. So we are right at the back of the disc on the left and almost there on the right. Just want to make sure he's comfortable. You having any pain? Where's your pain?
Where's your pain located? You having any pain in your back? Where is it? Can you speak a little louder?
Do you have any pain? Don't move.
Right
Right leg.
Okay.
Is it better?
Feeling better now?
Huh?
No.
He may be just pinching his nerve from laying there. Shot? You know what I mean?
Yeah.
Unfortunately, just laying on his belly could be contributing. Are you comfortable?
He said yes, he is comfortable now.
Where do you feel that? In your back? I need to know where he feels
Say
it.
it louder. In your back? Yes. Is it traveling down your leg?
Well, he already has the pain down his leg, so. Shot. It's very hard to see. We're right at the top of his L5. Shot. Now we're at the back. See that shot? So that has been deflected. Almost. You see how it's been deflected? Shot. That's about as good as I can get it on the right. See that right there? It's literally, I may be able to wiggle it in to the disc space, but even if I can't, I could still get in there later when he's more asleep. Now he's got already weakness going on in his legs, so he's in bad shape. All right. Shot. Once again, we're trying to get into this disc space that's almost completely collapsed, but may not be able to even get a discogram done. Shot. Yeah. Are you okay? All right. Good news, it's not as good as I wanted it, but we're right at the back of your disc. So, yeah, we're not going to get a discogram. Maybe. Right there. Shot? Maybe. I'll try. I'll try. Let's see. Shot? Oh yeah, we're not going to see it. I'll just put a little dye. It looks like it's in the disc. Go ahead. Go ahead, get in there. Don't let it all out. All right, we're going to go ahead and put our patient to sleep. Shot. And we're going to proceed. Whenever you're ready, Dr. B. Dr. B, whenever you're ready. I'm just giving you some numbing medicine, that's all. Lay still. Don't move. You're doing great. Just lay still. Thank you. So our patient has not just back pain, but pinched nerves very badly from his listhesis. And we're going to try to go in and unpinch the nerves and treat his back pain at the same time. He doesn't want fusion. I don't want him to have a fusion. Shot? All right, here we go. I've got my guide wire shot. Actually, the guide wire, I think, is going into the disc space. Shot, you see that? Yeah, it looks like it's in the disc, so we're good. This is really good news, folks. If you can get the guide wire in the disc space on one side, then I'm going to do a little trick. I'm actually going to bring, and he's an American, clearly, very patriotic. I'm actually going to get the dilator into the disc space, open those two bones up, spread them, and then once I get that in, I'm going to actually go from the opposite side. How's his blood pressure? Good? All right. I'm going to go from the opposite side and advance the other needle. So at this point, we couldn't really do the discogram. He's allergic to iodine. We don't want to put iodine. You're not going to see the dye that we typically put in. I did inject some blue dye. I think it is in the disc, so we'll see it when we get in there. But you won't see the x-ray dye because he does have an allergy. Oh, shot? Good. Alrighty, we're heading down. The other problem is he's got a very, you know, a thick back. Shot? All right. Let me know when you think he's ready.
He's ready.
All right. Henry, let's go ahead and show our audience, why do these herniated discs cause so much back pain? Welcome back. So what we've done is we're in on the left. We got our dilator, it opened the bones up, spread them apart, and then we went ahead and put our needle further in on the right side because we were bumping up against the back of the bones. But now that we've opened the disc space on the left, it also opened it on the right. We got our guide wire in on the right. Shot? Hold on. Now we just got to get our dilator out. Shot? Nope. It's pulling the whole thing out, huh? Yeah. All right. Now we just have to get the dilator out. Done. Hit the easy button. Just remind you he's very patriotic. Okie dokie. Any questions from our team?
No current questions.
Viewers.
No current question.
All right. We played the video showing why herniated discs cause back pain, right?
Correct.
That's good. Guys, I need the scope on. I need to see what I'm doing. Okay, there we go. Thanks. What's the problem, guys?
No problem, sir.
Look how much dye is in there. I can actually feel the needle from the other side. Huh?
Very blue.
Yeah, so we clearly got the dye in the disc, which is great.
It's a pretty one.
It is. Whew, it's a lot of blue dye, huh? What we need to do is get to the back of the disc where the tear and herniation are. all the pain's coming from this disc at least, on the right side, left side. Oh yeah. We're a bit overexposed, just a bit. Hold this here. It's going to want to back out. Just about done with this left side. Hold it. Are we back, Henry?
Yes, we're back.
Oh, I didn't know that. All right, very good. So they've seen, why does a herniated disc cause so much pain? Video. And this is it, right here, the annular tear. Full of inflammation. That's what all this stuff is we're seeing. Scar tissue, dystrophic calcification. Whoever thought the word dystrophic calcification would become a household word? Anybody? I'm going to make that word famous. Most doctors have no clue what it means. It's basically when your body does so much inflammation in a tissue that the tissue starts to develop calcium deposits. That's what we're seeing here. All right.
This is Ohio.
Huh?
Ohio.
There's the nerves, by the way. Those are the nerve roots. That's why he's had so much pain. This herniation is sitting in exactly the right spot. Now we're not going to fix his slippage. We talked about it. He didn't want to fix. I don't blame him. I think we can fix the pain without going in and fusing and fixing his slippage.
No cosmetic spine surgery done today.
Yeah. I mean, a lot of surgeons would do fusion, but he didn't want a fusion, and I don't blame him. To each his own. I wouldn't do a fusion either. If I could have Deuk spine operate on my back under these circumstances, I would do exactly the same surgery, knowing everything I know. Well, if you have questions, feel free to ask. I'll answer them for you. It's all scar tissue here from herniation, chronic herniation. Basically, we're debulking a tumor. The tumor is the herniation. It's not a cancer, it's just a tumor. If you look up the Latin word tumor, it means a swelling or mass. But herniation is a swelling, a mass. There's the nerve right there. You guys see the nerve?
Yes,
just
we do.
Underneath it. I'm trying to stay. It's scarred down, by the way. The nerve is scarred to this annulus from all the inflammation. It's scarred.
We have a question. This comes from AJ in the conference room.
Sure, AJ.
He asked, are you working within the dilator, or are you working beyond it when
I'm working
using
beyond the tube. So you can see the tube ends right there where the metal ends. We're working just beyond the tube. We're like sneaking out, poking our head out, working on the disc. The tube is retracting the nerve. You see the nerve right there? The nerve is all inflamed. Look how red it is. See that redness on the nerve root? It's
Yes, we do.
angry. It's pissed off, right? It's got inflammation on it. All this stuff is inflammation. So it's pissed. It wants relief. And somebody asked last surgery, how long does it take for all that inflammation to go away? Well, for this nerve, I think it's going to take a while, because he's got a lot of inflammation. But you can also see how easy it is to see the nerve, right? To avoid it, to not hurt it. It's right there, just outside the tube. As long as you're a neurosurgeon, shouldn't have a problem. That's the disc space right there, okay? We've done what we need in there. I just need to do a little more here, right outside the nerve. See that spot right there? That's the one spot I want to get, just under the nerve. Right there. Remember, I'm not going to get all of this fixed. There's no way to fix 100%. We just want to get enough that it makes this patient happy and pain-free for the rest of his life. Perfection is beyond our ability. But we can get pretty close to having a perfect result, which is to get rid of his pain and suffering. That is possible. All right, just about done. We got our guide wire in the other side, right? Yeah, there's the nerve right there. Beautiful, beautiful nerves. And I've done everything I can do. There really wasn't much to take away. It was just strategic. One down, one more to go, and then we're going to be doing his facets as well. We're not going to use betadine on him because, let me have the dilator, because he's got an iodine allergy. That's why everything here is white instead of the iodine color we normally see. One down, one more to go. I'm going to come to your side. Luis will apply some pressure. We'll put a staple over there. And I'm going to go fix the other side. Any questions?
No current questions.
Let me see.
So this is Ohio.
Yeah, he's from Cleveland, Ohio.
The machine is Ohio.
Oh, oh my.
Yeah.
Luis has just given me some exciting news. This machine we're using is from Cleveland, Ohio, and the patient is from Cleveland, Ohio. We just got this machine in. It's a new laser, and it's from, like I said, Cleveland, Ohio. So it's kind of funny how the patient's from Ohio and the machine's from Ohio. And the patient just moved to Florida and the machine just moved to Florida. So this is kind of a special moment where the machine and the patient both are new to Florida and now staying in Florida. Shot. Shot. I'm giving our patients some medicine to numb things up a bit. All right, we're coming down through that foramen. Shot. We're on the right side now. This is the leg that's bothered him the most. It's pretty tight. The good news is when we were able to get this dilator on the other side, it allowed me to get the guide wire in on this side hold on. Oh yeah, hold on, take that. Shot, perfect, yep. It's always hard to do these spondylolisthesis cases because the bones are sliding on each other and it narrows up the foramen pretty bad. That looks good. Great job. Perfect. We are in the disc. We're going to fix it. Any questions, Henry?
No current question.
That's odd we have no questions. Are we streaming?
Of course, yeah. Things are just running towards the end of the day here.
It's the beginning of the day for many people in the world.
This is true. This is true. But so far we have a pretty good crowd.
All right. Excellent. Well, here we are. L4-5 on the right side. You can see a little bit of blood from my work on the opposite side. Laser. Not uncommon. It'll go away. You can see the herniation. A lot of scar tissue. One of the things I like about the Homeomyag laser is the fact that it actually breaks up the disc herniation into smaller pieces with its cavitation effect, and it loosens them up, makes them want to come out. Makes the debridement a little easier to do. Beautiful. Here we go. So right after we do this, we're going to move on to our Deuk plasma rhizotomy, which is done without the laser. Oh yeah, there she blows. Any comments or questions?
None current comments or questions just yet.
All right, anybody do anything fun tonight since it is Halloween? Huh? Swedish meatballs? You're going to make Swedish meatballs. All right. I was thinking about scaring some little kids. I'm going to go home and put on my scariest outfit and scare the bejesus out of little children that come by.
We just got a question.
What's my scariest outfit? My scariest outfit is the Dr. Deuk outfit. It's when I dress up as Dr. Deuk Major. My staff gets scared. Yes, Henry.
We have a question from Allie on Facebook.
Yes, Allie.
They asked, can you have weakness in the limbs or fingers without pain? And did you ever do a coccyx repair?
Coccyx. Hey, you're so awesome. So the first question was, can you have weakness in the limbs without symptoms in the fingers?
Yeah, can you have weakness in the limb or fingers without pain?
Yes, you can. Yeah, you can have a pressure on your nerve or spinal cord that would cause weakness in the limbs or fingers without pain. It's certainly possible, yes. You need an MRI. And then, have I ever done a coccyx repair? So remember I told you earlier that we can fix 99.5% of back pain here. The coccyx is the one thing that we don't fix, right? And that's what I was thinking about when I said that, is the coccyx. So the way to fix a coccyx, we do a shot in the coccygeal ligament, and then if the pain comes back again, we could always do a surgical removal of the coccyx, where we go in and slice it out. Try not to do that because it's so invasive, but it certainly is an option. We got 5 minutes on this disc, and then we're done. This is all scar tissue, right where the nerve is.
We have another question.
Great.
This comes from Dominic on Facebook. And they asked, "Hi doc, how do you get the disc hernia that is outside the disc if you are inside it?"
Ah, Dominic, you have asked the $1 million question. I've answered it before, by the way, but I'll answer it again. When we put the dilator in, do you remember when I pound that thing in, that nail? That pushes the herniation from outside the disc back into the tear. And that is what I'm removing at this very moment. That huge thing right there. That's it. So great question, great observation. That's how we do it. I didn't discover the technique. It was taught to me by Dr. Anthony Young, Tony Young. He's the one who thought of it. And it works. Yeah, it's great. Great observation. Great observation. I hope you understand what I said. So if you go back and rewind, you remember we hammered that big dilator in. Then we put the sheath over it, and now we're inside. That dilator is what pushes the herniation from outside the disc within the neuroforamen back into the disc. And that's where I take it out from, inside the disc. It's called the inside-out technique. And it was pioneered and promoted and made famous by Dr. Anthony Young out of Phoenix, Arizona. One of my mentors, one of my teachers. In my opinion, my best teacher. He was the best. But of course, he only does the lower back. He doesn't do the neck or the thoracic. I had to do those. The neck I learned from the Koreans, South Koreans. Dr. Seng-Ho Lee, Dr. Gun Choi, founder of Woody Doll. I'm sure they have no clue who I am. They've probably never heard of me before, but that's who taught me. When they taught me, they didn't teach me like a professor would put his arm around the student and teach. I was part of a group that visited, and they taught the group, and I'm sure they don't remember me in particular because there were probably 50 other surgeons there, if I had to guess. And I wasn't anybody that they would remember. Just the truth. All right, almost done. There's a lot of scar tissue here, a lot more than I expected. So I'm really trying to whittle it away because I think this is going to help him a lot with his leg pain.
We have another question.
Sure.
This comes from Allie, once more on Facebook.
Uh-huh.
They asked if
Grab her.
it's the neck, does the dilator push herniations from inside to outside the disc?
No. All right, almost done. Just got to get a little more. Right there. Oh, it's beautiful. Look at that. See how much better you can see things when you put the grabber in there, the pituitary rondure? I've gotten rid of about 50% of the herniation at this point. I'm just starting to get into the high 50s. I'd like to try to hit 60% before we're done. All right, grab her. There is a little bit of bleeding. That's from the inflammation. Remember, there's a lot of inflammation here. All right. That's probably the last I can get right there. Here you go, Luis. You see what happens when you take the grabber out? The bleeding, a little bit of inflammatory bleeding resumes, and it makes it really hard to see. That's why I put the grabber in temporarily to see. All right, fine. Great questions today from our audience. Such an elegant surgery, you know, to be able to do this. This is all being done outpatient, by the way. For those of you wondering, these surgeries are all done in our surgery center. Patients go home usually within an hour or two of their surgery, the average being an hour. And when I say home, I mean obviously with these patients who travel from around the country, they're going to their hotel room. This patient, again from Cleveland, but now moved to Florida. Our laser is from Ohio, now moved to Florida as well. Luis, the laser's doing great. You happy with it?
Oh yeah.
Yeah. And John checked it out?
Go check it out, yeah, yeah.
Mm-hmm. Wonderful. Let's get some more. There's the nerve right up there. It's a little bit of blood vessel. I gotta stay just below that nerve. Right about there should be good. I want to get a little more of this. 30 seconds. Dr. B. Oh, yeah, we still have the DPR to do. The DPR is what? Bilateral 4551? Uh-huh. Thank you. You guys ready for the DPR? I just got one more laser thing here and we'll be done. Those are all pieces of herniation I was taking out. That's exactly the herniation that was sitting on his nerve. Laser. Oh, almost there, almost there. All right. Great job, everybody. Let me do the DPR next. We'll get the fluoro in. I'm going to show you right here. Here's an example of one of the pieces of herniation. And here's another one. You guys see this? Right here. There's 3. Here's another one, 4. You guys see it right here, Henry?
Yes, we do.
All right. So I need a roll. Let's get the pedal out. We're done with the laser. Great job. We'll get the fluoro in. Me? Thanks, everybody. Okay, we're going to move to our DPR, Deuk plasma rhizotomy, to treat his painful facet joints, because he has both disc pain and facet. Shot? Well, not far off. We're doing 4551, correct? All right, so
Just put a little local.
we don't, I don't know about no stinking local. Órale, vato. You like that? Hey. You ever see you ever see Borat? Or is it Borat? Which one is Vanilla Face? Which movie does he say which one does he say Vanilla Face? Henry?
Borat. Right?
Yeah.
Yeah.
Vanilla Face. I don't know about no stinking local. Batches? I don't know about no stinking batches. Which movie is that one from? Badges? I don't know about no stinking badges. That's another 80s or 90s movie. Essay? Badges?
Cheech and Chong?
Was it It could be Cheech and Chong. Really? Yeah. Can you type that up, Henry? Badges? I don't know about no stinking badges.
Copy.
Shot? All right, we are now going to deaden the pain nerves at the facet joint that are causing his facet pain. Shot? Perfect.
Gotcha.
Which one? Gotcha?
Yeah.
That's the name of the movie.
Yes, 1985.
Jeez. Who was in it?
This is a character, Malono, which was... Give me 1 second. Well, also, it was also in Blazing Saddles. It's actually... Yeah, it's actually acquired in a lot of films. But I think Blazing Saddles was the original when that line was delivered.
You may be right. I love Blazing Saddles.
Yeah.
Mel Brooks.
Yeah, because that movie came out in '74 and Gotcha came out in '85. So I don't know why.
I think it was the Mel Brooks. I watched Blazing Saddles a lot.
Yeah, same. I love that movie. Anything he makes.
Yeah, that's right. Badges. I don't know about no stinking badges. That was from Blazing Saddles. Great movie if you haven't watched it. One of the best comedies out there. With Gene Wilder, right?
Gene Wilder. Yeah. One of the best comedic actors ever.
All right, that's one down. Shot. Too low. Shot. All right, so I'm aiming for the junction of the transverse process and superior facet. Right there. Shot. Getting closer. Shot. Yeah, it's close. Pretty darn close. I'm hitting the facet because this facet is arthritic. But you want to be as medial as you can get. You want to be right in the valley between the transverse process and the superior articular facet, which is kind of right where I'm at. All right, and finally, the last one, shot. Shot. Right there. Shot. That's like perfect. Shot. Right, Jordan? I don't think we can do any better than that. All right, perfect. We're going to go to the other side. Yeah, it's perfect. Shot. Shot. So you can see the junction right by the needle tip, right there. Yep. Mhm. So Blazing Saddles, that's the movie for tonight. There's a lot of the newer generation, they don't know about the old, yeah. Mel Brooks, look up Mel Brooks movies. He was one of the best there ever was. Young Frankenstein. That was with Gene Wilder too, right?
His best one, in my opinion, is Spaceballs.
Spaceballs is my favorite. My favorite. Did you ever see the History of the World movies by him?
I've seen part 1.
Or the Monty Python's Quest for the Holy Grail? What was that, guys? Well, shot. It's concerning. There you go. Mega Maid has gone from suck to blow. Shot. If you've watched Spaceballs, you know what I'm talking about. Right, Henry?
Of course. We got to go ludicrous speed.
They jammed the radar.
Comb the desert.
I combed the desert. That's one of my favorite. Remember that? We ain't find shit. Comb the desert. Luis, you know what we're talking about? Huh? Oh, John Candy. His name was Barf in that movie. He was that human dog. Okay. Almost done. So far, everything has gone well. Just a little bit too low, but I guess I could do the S1 while I'm here. Shot. It's perfect for the S1. With the L5 dorsal branch. Dorsal ramus. Shot. Oh. Shot. So arthritic, his facets. Shot. That TP is abnormal there too. You guys can see how small it is. Huh? Tiny. We're done. Great job, everybody. Thanks, everyone, for your help today. Any more questions, huh?
No current questions.
All right, go ahead and end the broadcast. Thanks, everyone. I know he's going to do well.